Hello, everyone, and welcome back to Count to 10. My name is Ani, and on today's episode, I'm going to be looking at the 2025 first sitting paper that was just sat less than a week ago. Now, I have done a reaction podcast in the past when I looked at the 2023 second sitting paper. At that time, I distinctly remember there was really a shift to asking more clinically applicable questions, and that was a big change from questions that were just based on pure knowledge. Now, what I'm going to do for you today is a little bit daunting for me, and I'm a little bit nervous. I haven't looked at this exam paper at all, and I'm going to go in completely blind and go through what I would do in my 15-minute perusal in real time. So what this means is that I'm bound to make mistakes, but the reason I'm doing this is that so you guys can see what it's like going through the exam and know that we're all in the same boat, and this is a real struggle for everyone. Now, I sat the primary in 2022 in the first sitting, so it's been 3 years since I looked at a full paper and had this level of stress, and I can feel myself sweating already even before I get into the paper. So please be kind to me. Like I said, I'm going to make some mistakes, but I'm hopefully going to show you a template which I thought worked well for me on how I tackle the perusal time. Because 15 minutes isn't very long, as you guys know, 1 minute per question. What is it that you're trying to get out of it that actually gives you an advantage to when you start writing down your answer? So I'll share with you what my 5 tips are and the approach I take. And with that said, let's dive straight into the exam.
1, 2, 3, 4.
So just a disclaimer before we get started, I'm not going to be giving you a model answer for each one of these questions. The purpose of the exercise is for you guys to see in real time what it's like for someone to go into an exam completely blind and be going through their motions on what they do in their perusal time, so that hopefully you can take away some tips. And in saying that, you can also see that everyone gets a little bit nervous and makes mistakes, and hopefully you can avoid these mistakes in the future. My 5 things that I try to do with any question starts with first, which is really simple, but that is often overlooked, and it's the easiest piece of advice anyone gives you, which is read the question properly. What commonly happens is either you read the question and halfway through, you predict what the question is going to ask, and your mind already starts to write down stuff in the perusal time or think about what you're going to write. Or the other thing that happens is that you start to read the question, think you know what the question is, and then quickly move on to the next one. The first thing I like to do is just read the question for what it's at face value. The second thing I do is once I've read the question, I read the question again, but this time highlighting the key definitions. And what I mean by definitions is looking for those terms specifically like describe, compare and contrast, outline, list. This will give me an idea of how much detail I need to put in my question. And with this, I also look at any percentage breakdown with each SAQ question. So is this question worth 10%, 50%? What are the sections? And is this section percentage giving me an indication for time, or are they specifically telling me the marks that are allocated? Typically, the percentages are telling you the time that you should put for each component of that question. Then the third thing I do is I look at the question and see what part of the curriculum is this covering. Is this a cardiovascular question? Is this a respiratory question? Is this a pharmacology question? Is this a equipment question? And with that, I ask myself, why are they asking that question? What is so important about this question in terms of the importance to the examiner that they want us to know about this question? This leads on to my 4th point, which is what is it that I can't miss when answering this question? And this can be different for each different person. Sometimes a can't miss can be, this one caveat about a drug. Or a can't miss can be a really obvious thing that you have to say, I have to put a diagram in for this question because this will help make my answer better. So step 3 and step 4 kind of go hand in hand, which is what part of the curriculum is this question coming from? Why are they asking this question? And then what can't I miss? And the what can't I miss can be one thing or two things, but I like to keep it really simple and just think about one thing I can't miss that I have to put down for this question. And usually that one thing that I can't miss is something about clinical relevance because I always feel like that gives me a little bit slight edge in my SAQ. Then I get to my fifth point. And this point, by this stage, you're already kind of at the 45, maybe even used up your whole minute in your perusal allocated for that question. But that is quickly thinking about the structure. I'm not necessarily writing down the structure when I'm thinking about it because I feel that's a waste of time. Like, I'm not going to write down for a pharmacology question, I'm going to structure this question ADME. You already know this because you've been doing this for ages. So just writing that down is not going to help you, in my opinion. What I'd rather do is just think about, do I have a structure? Yes or no? And if I don't have a structure, what structure could it be? And if I can't think of it, move on. And at least I've started to think about this in the back of my brain as I look at the other questions. So those are the 5 things that I go through when I'm looking at each one of these questions. And sometimes I won't get through all 5 because the question is just so out of the blue that I've not thought about it before and I get stuck at the first one. The most important thing is step 1. Just read the question for what it says. Don't take in any of that extra stuff, but just read the question. If you do that, you'll be able to write at least something. So those are my 5 key points that I think about in the 15 minutes of perusal, and hopefully you can take some of those on board with you, or you can just not use any of them. It doesn't bother me. The thing is, me doing this activity will hopefully give you an idea of what it's like when you're sitting the exam. So now I think we're ready for me to look at these questions and do the 15-minute perusal. I'm really nervous. It's been a long time since I've done this. So if I make a mistake, so be it. I expect to make a few mistakes as I go through this, but hopefully I'll keep that structure, and you'll see even when you have a structure in the real exam, your nerves do get the best of you. So it's important to just practice your structure and have that down pat so that in moments where you're a bit flustered, you just go back to it. And you can do this at home if you're listening, or I'm going to be uploading this episode up on YouTube as well, and you can watch me do this. I've got the exam paper ready to go. So on the count of 3, we're going to start. 3, 2, 1. The first question is airway anatomy. Answer in a separate book provided. I hate separate books, but here we go. So first question, the above images show nasal structures as seen with a fiber optic scope. Name these structures. What is the innervation of A? Then a front on view. Name the surface anatomy landmarks which are labeled on the above images. 4 marks. 4. On the above image, draw and label the structures which are relevant to performing a surgical cricothyrotomy. 12% of marks, 12 marks. 5. The structures labeled X on the above image. This is just a glottic view. Describe 1 point of clinical relevance to anesthesia of the structure labeled X. On the above image, draw and outline the arytenoid cartilage, and to show clearly their shape and position, outline the function of the arytenoid cartilage, describe positions of the cuniculate and cuneiform cartilages. So that's already taken a minute, but I know this is an airway question. I know I have just to go through it. There's no specific things I can miss in this. So just go through my booklet and think about the most important marks were for 12%, 12 marks for performing a surgical cricothyrotomy. That's already more than a minute up. Going to my next question. Question 2. Discuss respiratory system compliance, including the factors that affect it. So read the question again. It's asking me discuss. There's no percentage marks associated with this. It's talking about the respiratory physiology and why it's important. Compliance is a very easy topic. So then what I can't miss with the respiratory compliance is respiratory system they're asking me about. So it's both chest wall and lung compliance and compliance in total. They haven't specified an age here, so that's going to be in my back of my mind. So my structure is just going to be the factors, an important definition, and then looking at the factors. So then I'm going to question 3 now, which is explain how hyperventilation causes a respiratory acidosis. Outline how renal compensation for a respiratory acidosis occurs. So reading the question again, my step 2, the first part is explained. So that's just a quick kind of a step down from describe in my head. There's 25% of marks allocated to that, so I should be spending 2.5 minutes. Then the second part is outline, so they just want brief points on how renal compensation for respiratory acidosis occurs, and 75% of the marks are here. So they want majority of the time to be spent here. In terms of what I can't miss, so what I'll be thinking about is the CO2 and the reabsorption of CO2. I'm thinking about where in the renal pathway is renal compensation occurring. So a key thing I can't miss is mentioning the action of carbonic anhydrase and how that works in terms of compensating for hyperventilation. And then my structure would be, in terms of this, I can't actually think of a good structure at the moment, so I'm just going to move on. Then question 4, describe, label, and... So I've already read this wrong. Draw, label, and describe the waveforms and pressures that are seen in each anatomical location during insertion of a pulmonary artery catheter. So here, reading the question again, I've been asked 3 different definitions: draw, label, and describe. And here the question is asking about pulmonary artery catheter. It doesn't have any percentages. Those are my first step 1, 2, and 3 done. What can't I miss? I think the main thing I can't miss is here drawing the catheter really well in terms of the waveforms. If I draw it well, I'll know what happens in the right atrial pressure, the RV, and then going into the pulmonary artery and getting the left capillary wedge pressure. The key thing in my brain is remembering that the RV will have no diastolic pressure. So my structure would be exactly what it says: draw, label, and then describe the waveform. Then moving on to question 5, outline the mechanisms of peripheral and central pain sensitization. Do not discuss pharmacological treatments of pain. So reading the question again, it's an outline question. So this is brief points on both peripheral and central pain sensitization. There's no percentages allocated to this. What I can't miss is that both with peripheral and central pain sensitization, I have in my head the 2 things, which is both... What am I thinking about here? I know of the 2 terms, but I can't think of them. I want to talk about the wide dynamic range receptors. I want to talk about things like allodynia, and I want to talk about hypersensitization, or hyperalgesia and allodynia. So those are the 2 key points that I can't miss in my head. So I'll just structure this question in the form of going from the periphery to then the central in terms of the structure on how I'm going to go through the mechanisms for sensitization. Then moving on to question 6, explain the initial and subsequent distribution across the body fluid compartments of a rapid bolus of A, 1,000 mils of compound sodium lactate Hartmann solution, B, 1,000 mils of 5% albumin. So here, going through my definitions, is asking explain, and they've highlighted the words initial and subsequent, but they've only asked me to explain. So this is brief kind of outline, similar to outline, a step down from describe. There's no percentage marks, but I'm going to give myself equal percentage for Hartmann's and albumin. And then what I can't miss is that they've asked specifically for initial and then subsequent. So remembering that albumin will mainly stay within the intravascular space. So again, I would structure this as initial and subsequent distribution. So that'll be my overall structure for this question. So I'm 20 seconds behind now. So moving on to question 7, explain how blood glucose levels are regulated for the duration of a 48-hour fast. So read the question again. Explain is the key definition here, and there's no other percentages that are attached to this. In terms of what I can't, or what this question is covering, so it's covering endocrine physiology. The key things that I can't miss here is a 48-hour fast has 3 phases in it. So you have the initial phase where you use up, and then you have the ketotic phase at the end. So I just got to remember those 3 phases, and I'm going to just structure my answer based on those 3 phases of using glycolysis, using the carbohydrate storage, and then using the ketotic storages. Then question 8, discuss the concept of half-life and context-sensitive half-time. using fentanyl and remifentanil as examples. So reading the question again, the key word here is discuss. So they want a little bit of detail, a little bit below than describe, but higher than explain or outline. The key terms here are half-life and context-sensitive half-time. They haven't asked for any kind of percentage breakdown. This is obviously covering pharmacology with a mix-in of opioid and general pharmacology principles. What I can't miss here is making sure that I know the definition for context-sensitive half-time, which is when an infusion is seized and the time it takes for that plasma concentration to decrease by half. So therefore, it's context-sensitive. And the other thing I want to just make sure I remember is they're using the examples fentanyl and remifentanil. So in my structure, I would just have those two concepts, and I would have those two drugs, fentanyl and remifentanil, as examples, and then talk about them in terms of their PK data. So question 9, describe the cardiovascular effects of sevoflurane. So reading the question again, the question is asking describe. So you want a lot of detail here, and it's focusing on the cardiovascular system. So the system, or what the question is asking, is for the cardiovascular system. The question is obviously important because we use sevoflurane all the time. There's no percentage breakdowns with this. What I can't miss with this is breaking the question down into the effects on the heart, the peripheral system, thinking about both the pulmonary circulation and the systemic circulation, and then what the effects would be for clinical relevance with different age groups. So that is in my brain, my structure as well, and the extra point in the back of my brain. So question 10, describe the structure and function of the NMDA receptor. Describe the interaction of ketamine with this receptor. So reading the question again, both the important definitions here are described, so they want a lot of detail. There's no percentage marks allocated with each one of these, but it's 2 parts, so I'm going to put 50% on each. This is going back to pharmacology and kind of covering pharmacodynamic principles. And then you have an important drug for us clinically, which is ketamine. So you can see why this question would be asked. What I can't miss here is that the NMDA receptor has calcium or has magnesium attached to it. Ketamine is a non-competitive antagonist, so therefore it works at a different site. And my structure for this would be a pharmacodynamic structure on how the drugs work. So a mechanism of action and relating this back to how ketamine and the pharmacological properties of ketamine. Question 11, discuss the factors affecting speed of onset of blockade of a major peripheral nerve with local anesthetic. So reading the question again, the key definition here is discuss. There's no percentage breakdowns. This is obviously relating to both pharmacology and local anesthetics, so this is a key topic and you can see why this will be asked. The question is asking specifically speed of onset, so I can't miss that. And in my head, I'm thinking about the key thing being the pKa of drugs on how they affect the speed of onset. So then my structure would be listing the factors that affect the speed of onset, and this could be physiological factors, pharmacological factors, and then other factors. Then question 12, compare and contrast the pharmacology of metaraminol and ephedrine. Reading the question again, the key word here is compare and contrast. They've not given any percentage breakdowns. The question is obviously covering pharmacology of 2 drugs from cardiovascular pharmacology. So why is this important? Key drugs we give all the time. The key thing I can't miss is that ephedrine has the beta-1 effect. They're asking for comparing and contrasting the pharmacology. So my structure here would be talking about the pharmaceutical preparations first, then talking about the pharmacodynamics, and then going into PK. Clinical context, can I put something in here extra? Because I have like 5 more seconds, I've caught up a bit of time. I can't think of anything at the moment. So going to question 13, outline the pharmacology of following anticoagulants, dabigatran and rivaroxaban, using the following headings: mechanism of action, important pharmacokinetics, time for onset of effect when seizing preoperatively, and reversal. So reading the question again, this is an outline question. There's no percentage breakdown, but they've given us 2 drugs. So it needs to be 50% either way. What is this covering? Obviously, pharmacology of anticoagulants, so coagulant agents. Important for us in many respects for, before patient preoperatively and intraoperatively. What I can't miss, dabigatran, it's a direct thrombin inhibitor, rivaroxaban, factor 10A. Reversal agents in my head, we have Adnexa and we have Digibind. Not Digibind. I can't think of the one, but I know we have a reversal agent for dabigatran as well at my head. And my structure is just going to follow the mechanism of action, important pharmacokinetics, and those headings that have been listed out, time of onset, offset for effect. So we have 2 minutes left now. Question 14, list the components of innate immune system. For each component, outline its role. Reading the question again, keyword here is list. So you don't need to know anything else apart from that. And it's asking to outline its role. So there's 2 key definitions here. There's no percentage breakdown. What is this covering? Obviously, immune system. Why is this important? We do a lot of things in anesthetics that break down the innate system barrier. And how I can't miss in this is my 3 kind of physiochemical barriers, the cellular components, and then we have your your complement system. So physiochemical barriers, your humoral component, and your cellular components. And that'll be my structure as well as what I can't miss for this. And the other thing I'd be thinking about is how anesthetics affects the innate immune system. So that'll be my extra points, like putting a cannula in. So moving on, last question, got 45 seconds left. Define the following terms: trainer 4 count, trainer 4 ratio, post-tenic count. Explain the physiological basis of these tests and how they are used clinically. So keywords here, definitions, define and explain. Define is just a quick, it's 30%, so I should be quick at that. Explain is 70%, so I need to think about this more. In terms of what is this covering, obviously neuromuscular drugs. Why is it important? We use them all the time. What I can't miss is knowing the differentiation between trainer 4 count and ratio, and then what is a normal level of reversal that we'd want, and then explain the physiological basis of these tests. So this is an electromyography or an acceleromegrapher, and that's my time. So what was I trying to say at the end there? I think I was trying to say acceleromegraphy. And you can see that 15 minutes kind of flew by in my head, and I probably made a lot of mistakes during that 15-minute perusal. I recall around about question 6 or 7, I forgot to talk about what system this question was covering in terms of whether it was a physiology question, pharmacology question, and why it was important. And then I went back to that as I went in for the last few questions. So my system came back in, and that's why you need to have a system, because it goes, okay, why is this question important? And that kind of helped me, just reflecting back on my own performance in this kind of going through this perusal, be like a bit more detailed in how I was going to go about the structure of the question and what I thought I couldn't miss. Because before, at the start, I think I was very all over the place for the first 3 or 4 questions. And having that first question of having a booklet that's separate really threw me off, because that booklet just kept going, like, really? And then you start thinking about your head, you're like, oh, what is those images that you're actually trying to look at? The key thing here is that hopefully you see that I've made some mistakes when going through the perusal. Even when I was trying to read some questions, because of the added pressure, I initially read some of the words wrong. I had to go back and read it again. And that's okay, as long as you go back and read it again. So, what did I think? Overall, I think this exam paper is relatively fair. Now that we have a bit more time, we can go look at these questions again. So the first question, just going through them in chronological order. Airway anatomy. So this is obviously covering respiratory physiology, and this is really important in terms of it also covers kind of crisis management at the same time. Here you have a photo of the nasal passage, and you have what looks like a turbinate as one, and then the septum as the other structure. And then in terms of innervation, you just need to know what nerves are being blocked at the nasal component, because the three nerves that we block are cranial nerve 5, cranial nerve 9, and cranial nerve 10 when we're doing an awake fiber optic. Then we're talking about a front-on view of someone's neck. So they want you to name the Adam's apple or thyroid prominence from the thyroid cartilage. And then they want you to highlight the cricoid cartilage, and in between you have your cricothyroid ligament or cricothyroid membrane, whatever you want to call it. And then you have your sternal notch at the bottom. Then the important thing with this question is that they want you to go through your surgical cricothyroidotomy technique. The key thing here, and you can see how I've already made the mistakes, do not describe the steps in performing a cricothyroidotomy. On the above image, draw and label the structures which are relevant to performing a surgical cricothyroidotomy. So here, you'd be referencing question 3 to help you answer question 4. And you can see, even when you're going through this, you think you've read the question right, you can easily, I've made the mistake there of thinking about my steps. The question didn't ask for the steps, it just asked you to draw and label. And if it's asking you 12% of the 12 marks allocated to this section, it's obviously going to be a big part of this question. This is more questions that are coming from the kicking exam, because the kicking exam loves to ask about airway anatomy. I don't know why our exam doesn't like to ask about it more often, but I think that's definitely coming in more. And I wouldn't be surprised if it went down the track of future questions being asked about describe the anatomy of the diaphragm and the function of the diaphragm, because that's also really important for us. And that's also been previously asked in the kicking exam. So that's question 1, and that really threw me off. But then we move on to question 2, which is describe respiratory system compliance, including the factors that affect it. This has been a question that's been asked multiple times. Respiratory system compliance been asked multiple times. The way I would structure it would obviously be covering both chest compliance and lung compliance, because that falls under the whole respiratory system compliance. The question is asking you to discuss. So discuss means, in my head, not as much detail as describe, but not as little detail as outline. So somewhere in between. And this is obviously another respiratory question. So 2 respiratory questions to start off the exam, followed on with a third respiratory question that kind of goes with acid base, which is the third question is explain how hyperventilation causes respiratory acidosis. So here I'd be thinking about my Henderson-Hasselbalch equation in the back of my mind. So some of these words just didn't come to me when I was thinking about my perusal. I'd be thinking about how in the second part, renal compensation for respiratory acidosis occurs. I talked about how the key thing I couldn't miss was talking about the role of carbonic anhydrase and thinking about how bicarbonate is reabsorbed during that pathway through your proximal convoluted tubules, your loop of Henle, and then your DCT. So bicarbonate is reabsorbed in all of these different areas to a different varying degree by different types of cell. Then moving on to question 4, draw, label, and describe the waveforms and pressures that are seen in each anatomical locations during insertion of a pulmonary artery catheter. So here, the key thing again that I think you can't miss is that you need to draw a good diagram of your pulmonary artery catheter. And then the waveform changes based on whether you're in the RV, whether you're in the pulmonary artery, whether you're in the pulmonary capillary wedge pressure, which then equates to you having the left atrial pressure. The thing I think I said was with the RV waveform, there's no diastolic pressure. So it's typically something like 25 on 0. And as soon as you get diastolic pressure, that tells you that you're in the pulmonary artery now and not in the RV. So that was the key thing in my head. Might not have conveyed it when I was trying to go through it, is that I remember that's an important thing with the waveforms for how to know when you're out of the RV. Then question 5, this is a doozy. I always think pain questions are always a bit of a doozy. Outline the mechanisms of peripheral and central pain sensitizations. Do not discuss pharmacological treatments of pain. Here I really struggled to come up with the words of hyperalgesia and allodynia. And you can see how when I was trying to think about that, I was really wasting a lot of time. This is a very book heavy or theory heavy question, and they've obviously asked you not to talk about pharmacological treatments. So this is covering pain pharmacology, and I think if you know pain pharmacology well, which is a hard topic to learn, you would have been pretty happy with this question. Then the next question is one that I think reads really easily, but is actually really hard to write down and explain. And which is question 6, explain the initial and subsequent distribution across body fluid compartments of a rapid bolus of both 1,000 mils of Hartmann's and 1,000 mils of 5% albumin. You know what this question is trying to ask you. You have a crystalloid solution as one, and then you have a colloid solution as the other. You know the crystalloid solution is relatively balanced. 25% of it will stay within the intravascular space. Initially, majority of that fluid will stay within the intravascular space, giving you an initial rise in your blood pressure. And then as that fluid equilibrates and distributes, it will follow the normal body fluid pathways or the body fluid compartments. And then your two body compartments are either your intracellular or extracellular. And within extracellular, you can think about your intravascular and then your interstitial space. The hard thing I think in this is commonly people don't know the half-lives of the distribution, but having a relative guide in your head, and I think Ketamine Nightmares has a good similar model answer SAQ to this that describes the half-life kinetics of this distribution and how long it takes between the initial and then the subsequent distribution phase. So if you can go over that, when you've looked at the previous questions that have described what happens with 2 liters of infusion of a Hartmann solution, I think you would have been fine. And then with albumin, realizing it's a colloid, majority of it's going to stay within the intravascular space. Little of it's going to pass. However, there are going to be certain areas where the membrane is permeable to albumin and some of it will pass as well. So majority of it will stay in the intravascular space. And I think that key differentiation between what happens later on with a crystalloid and a colloid would have been the can't miss thing that I couldn't forget in this answer. Then we move on to question 7, which is when I think it clicked into my head that I wasn't talking about what section of the syllabus the question was being asked from. Again, I was fumbling through my words, but I knew what I wanted to say in my head, which is that there's 3 steps to fasting or 3 stages that occur with fasting. The initial use of glucose, then the glycolysis phase, then you have your gluconeogenesis phase, and then you have your ketotic phase. None of these questions are easy, but what I'm saying is that there is a template model answer for this in the past. Then we move on to question 8, which is a pharmacology question, which is discuss the concept of half-life and context-sensitive half-time using fentanyl and remifentanil. And it's funny because I just did a general pharmacology episode on the principles of pharmacokinetics where we talked about half-life and context-sensitive half-time and how these two terms are similar but different. And I think there is a huge number of past SAQs that help you answer this question. Then question 9, describe the cardiovascular effects of sevoflurane. This is a repeat, obviously really important because we use sevoflurane all the time. Cardiovascular effects, you need to know about this. And I think in my head, I would break it down into the different parts of the cardiovascular system. And clinically, what I was trying to remember is you can talk about the cardiovascular effects being different in different age groups. And the 2 age groups I would have had in my head would have been the shocked patient, the elderly patient, and then compare this with a normal, healthy 40-year-old adult. Moving on to question 10, which was describe the structure and function of the NMDA receptor, describe the interaction of ketamine with this receptor. We know why this is important. We use ketamine all the time. Now with opioid-free anesthetics being more prevalent in general kind of practice and the use of ketamine being more and more prevalent as well with the ROCKET trial, you can see how this question would have come up. Moving on to question 11, discuss the factors that affect the speed of onset of blockade of a major peripheral nerve with local anesthetic. This is again a favorite question. We use local anesthetics all the time. The factors that affect speed can be physiological, pharmacological. They're typically pharmacological factors or other factors like how close are you to the nerve? Did you use an ultrasound to place the local anesthetic next to the nerve? Did you penetrate the fascial bundle of the nerve? Those kind of things will also affect the speed of blockade. So they're more logistical things, that I kind of put into physiological factors, or we can put it into other factors. Then moving on to question 12, compare and contrast the pharmacology of metaraminol and ephedrine. They're commonly used drugs that we don't use often. In the KIM exam, they ask questions like dobutamine with other drugs. We don't really use adrenaline and noradrenaline too often. I guess if you're doing cardiac or you have a really sick patient, you use those drugs. But I think asking about metaraminol and ephedrine, that two drugs that are commonly used for two different varying purposes. Commonly used ephedrine to say someone is hypertensive and slightly on the bradycardic side. So that tells you the thing that you can't miss with ephedrine is knowing is it has its beta effects as well. Metaraminol has some beta effects, but they're very minor. The alpha effects really predominate. And that would be the key thing that I'm trying to think about in the clinical reasoning, or the special thing that I'm trying to put in my table, because it's asking you the pharmacology. So you're thinking about pharmaceutics, pharmacodynamics, and pharmacokinetics. And I'm thinking about clinical relevance at the end as my special kind of caveat to differentiate myself, to hopefully get myself some extra marks on what makes the difference between metaraminol and ephedrine. Then this is a new variation of a question I think that's been asked in the past. Like we've been asked about rivaroxaban, we've been asked about warfarin in the past. Question 13, outline the pharmacology of the following anticoagulants, dabigatran and rivaroxaban. In this question, what they've done is they've given you the headings, and you just need to make a table, whether you make a table, columns or rows, in which way you have dabigatran and rivaroxaban, but those are your headings that you have already listed out. And I couldn't think of the reversal agent for dabigatran. I know rivaroxaban has adnexanet, something MAB, but I can't remember. I know it's a MAB agent, but on top of my head, I can't remember it at the moment. But those are the important things for the last part, which is the reversal. You can see why this question is being asked, because a lot of people are being on these NOAC agents or DOAC agents. So you need to know the mechanism of action. We're commonly nowadays not in charge of knowing when to stop these drugs, but in some places we might be. So you need to know the duration of action of these drugs. Importantly, if you're going to put needles in people's backs or do kind of any invasive procedures, you need to know what is the safe length. And that will also vary depending on renal clearance. So the thing that I would have gone back to say I can't miss is the adjustment for renal clearance, and knowing that these drugs have a reversal agent, which is kind of a given because they've given you the heading of having a reversal agent. Then we move on to question 14, which is list the components of innate immune system. This is, again, a question from Kickham. They love to ask about immune system. They specifically asked about innate immune system. And if anyone who's done a Viva with me knows, I love to ask about innate immune system, because a lot of things that we do that break down this innate immune system. So we have the physicochemical barriers, we have the humoral and the cellular components of the immune system. And the special thing that I'll be talking about, because it's asking you to outline its role for each component, is I'll be also thinking about the clinical context. So with anesthesia, so we can put NGs down, we put ETTs down that impair your cough reflex, we put a cannula down which impairs your skin barrier, we give drugs that also impair cough reflexes. So some drugs that we'll give to decrease nausea and vomiting, like steroids, will have a negative effect on decreasing the immune system response. All these drugs that we give and things that we do, you can see why they've targeted this question on the innate immune system. Then finally, the last question is define the following terms: trainer 4 count, trainer 4 ratio, and post-tetanic count, and then explain the physiological basis of these tests and how they're used clinically. I think I kind of misread the second part of the question here, because I was thinking about acceleromiography, which is the process of what we're doing for this kind of procedure to get a trainer 4 count or a trainer 4 ratio. But the physiological basis is looking at what's happening at the neuromuscular junction. And if I had time again, that'd be the can't miss thing. What is happening at the neuromuscular junction between the non-depolarizing agents and the balance with ACH, which leads to you having a trainer 4 count, which then leads to you having a trainer 4 ratio. And if you're too deep in terms of your blockade, you do a post-tetanic count. And how does this correlate with a trainer 4 count in terms of knowing what the dose of reversal is going to be? Do we need to use something like Sugamidex, or can we just use standard reversal? So I think this is a variant of a question that's been asked in the past. There's a lot of questions here that are variants of questions that have been asked in the past. I just wanted to quickly go through them. I think Stan Tay still does the best review for each one of these questions on his YouTube channel, which I would highly recommend for you guys to review. The purpose of my episode today was to show you that I also get nervous, that I also struggle with the exam, and that you can see what it's like in real time, someone reading the questions for the first time and going through the 15-minute perusal. You can hopefully have a structure that you can take or leave, but you can see how even when you have a structure, with the stress of things which happen to me, you can read things wrong. Despite everyone saying that step one, or my advice, step one is to read the question and read it without looking at anything else. I can still see how I read some of those questions wrong. Step two is looking at the definitions and the time allocated to each question, or if there's not time, the percentage allocated to each question. Step three is thinking about what part of the curriculum is this question coming from and why are they asking this question? What is so important? And you can see each one of these questions is coming from a place where an examiner could justify why this is a really important piece of curriculum for you to know. Step four is then thinking about what you can't miss. And these two steps, step 3 and 4, kind of link together. And sometimes step 4 and step 5 kind of link together. When you start thinking about what you can't miss is when you start to think about the structure of how you're going to answer it. But sometimes that's the last thing for me, because if I want to start my brain thinking about the question, the structure will just come with it. So those are my 5 kind of tips in the perusal time, and hopefully that helps you going on with your exam in the future. And with that said, that brings us to the end of today's episode. I hope you guys enjoyed it. My armpits are really sweaty. I am all nervous out, and I'll catch you next time on Count to 10.